Hello students, welcome to the session of Paediatrics, and today the topic of the day we are going to discuss here is the rheumatic fever. We are going to discuss here is the rheumatic fever. Now rheumatic fever is the most common acquired heart disease in children in India. Heart disease in children in India, this is the rheumatic fever. And you all know basically rheumatic fever usually follows group A. Group A streptococcal infection. This usually follows is the group A streptococcal infection, right? So it is so called a child particularly gets is a group A streptococcal pharyngitis, right? And this is particularly by the strains M type. Strains M type, that is 1, 3, 5, 6 and 18. So a child gets streptococcal pharyngitis with these strains and there can be rheumatic fever, right? The point, the MCQs which has been repeated, only 3% of streptococcal pharyngitis. Only 3% of streptococcal pharyngitis that develop rheumatic fever. Only 3% they develop rheumatic fever. So it is not that the rheumatic fever is particularly seen in every streptococcal pharyngitis. It is only seen in only 3%. The most common age group which is particularly affected is 5 to 15 years. This is the age group, most common age group, that is 5 to 15 years, which is particularly affected is, right? Then in approximately 2/3 of the cases of rheumatic fever, 2/3 of the cases of rheumatic fever, there is history of pharyngitis. What I mean to say, still in 1/3 of cases of rheumatic fever, you are not able to get the history of pharyngitis. This is also a line to be remembered, right? So in 1/3 of cases of rheumatic fever, there is no history of pharyngitis. There is no history of pharyngitis, right? Then if we go to the revised modified Jones criteria, which we use particularly for the diagnosis, right? First it was modified, so now we are saying is revised modified Jones criteria and we go for the diagnosis. Now particularly rheumatic fever, the criteria is different in low risk population and it is different in high or moderate risk population. So one we say is the low risk population, and another we say is the moderate or high risk population. Now, what is the criteria for the low risk? First, we look at the incidence. And the incidence, you look at the school age children. The incidence in low risk population is less than 2 per 1 lakh. In moderate to high risk, it is more than 2 per 1 lakh. So this is something you define here as the what is the incidence criteria in the low risk and in the moderate to high risk. Second is the prevalence. And prevalence basically you look in all age group. In low risk it is less than 1 per 1000. This is more than 1 per 1000. So this is what we say is the low risk and this is what we say is the high risk. So this is the first, we define it as low risk population, that is mainly developed countries. This is moderate or high risk population, mainly India. So India comes in the high risk population. Then what is the diagnostic criteria? First for the initial episode. What is the diagnostic criteria for the initial episode? In the low risk, what you say is 2 major or 1 major plus 2 minor criteria, 2 minor criteria plus evidence of streptococcal infection, plus evidence of streptococcal infection. Either 2 major criteria is present or there is 1 major plus 2 minor criteria plus evidence of streptococcal infection. This is in low risk. The same is here, same as in low risk, same as in low risk. What is the criteria for recurrence of rheumatic fever? Criteria for recurrence of rheumatic fever in the low risk, it is same as above. Same as above, and here it is same as above or three minor criteria. So 3 minor criteria can be used as the criteria for diagnosis of acute rheumatic fever in recurrence in moderate or high risk population. That is something which is there. So this is the criteria we say now. So now we discuss first is the major criteria. Major criteria, and first major criteria we say is the subclinical or clinical carditis. So it is not only clinical carditis. Clinical carditis is something that is valvulitis with murmur. The murmur is audible, and subclinical which you detect on echocardiography. So this is subclinical or clinical carditis in low risk. It is same as in low risk. Same as in low risk. Second criteria here is polyarthritis. Here it is polyarthritis. But in the moderate to high risk, it is polyarthritis or monoarthritis or polyarthralgia. Polyarthralgia. Right? So this is something extra which you need to remember here. Monoarthritis or polyarthralgia are the major criteria in moderate to high risk population. Third major criteria is erythema marginatum. Erythema marginatum. So this is here also, and here also it is same. Fourth criteria is the subcutaneous nodules. Fourth criteria is the subcutaneous nodules. Here also it is same. And fifth criteria here is the Sydenham's chorea. Sydenham's chorea. This is also same here. This is also same here, right? So this is basically the 5 major criteria, and the difference is in the polyarthritis in the low risk, but in the moderate to high risk it can be polyarthritis or monoarthritis or even polyarthralgia, right? Then we consider is the next point minor criteria. We consider here is the minor criteria, right? So if we consider here minor criteria, first we say is the ESR. ESR, in low risk it is more than 60 millimeter per hour. But in the moderate or high risk it is more than 30 millimeter per hour. It is more than 30 millimeter per hour. Then we consider is the CRP. Here it is more than 3 milligram per deciliter. Here also more than 3 milligram per deciliter. Then is the prolonged PR interval. Prolonged PR interval. And here also it is same. But the difference lies particularly where now again in the fever. Here it is more than 38.5 degrees. But in the low risk, in the moderate to high risk, the criteria becomes more than 38. That becomes more than 38. Then here is arthralgia, and here the criteria is polyarthralgia. Now look at the difference. Polyarthralgia is a minor criteria in a low risk, but this is a major criteria in the moderate to high risk. And here it can be monoarthralgia or polyarthralgia. So if you see which minor criteria are different, one is the difference of ESR, one is the difference of the fever, one is the difference of arthralgia. Then we say is evidence of streptococcal infection. Evidence of the streptococcal infection, and this should be present in both. If there is no evidence of streptococcal infection, there is highly unlikely it is a case of rheumatic fever. Now, how do you look for the evidence of streptococcal infection? There can be positive throat culture. There is positive throat culture. Or you can do is the rapid antigen test. And you can measure is particularly antibodies against streptococcus. And particularly which are the antibodies we measure? We measure is the anti-streptolysin O. We measure is anti-streptolysin O. We measure is anti-deoxyribonuclease B. We measure is anti-hyaluronidase. So ideally speaking, if you only measure ASO, it is only positive in 80 to 85%. But if you measure all the three, they are positive in 95%. So unless only major or minor criteria is not sufficient for diagnosis, there should be evidence of what? Streptococcal infection present in both these. Right. Now we discuss certain points regarding the major criteria. We say the certain points regarding the major criteria. First is subclinical or clinical carditis. Subclinical or clinical carditis. Right. So what we mean to say here particularly, subclinical is valvulitis without murmur. So whether it is subclinical carditis or it is clinical carditis, both of them they carry the same value. Right. Both of them are included in the major criteria. Clinical carditis means there is valvulitis with murmur present. So why the heart is typically being involved in rheumatic fever? Now this is something which is what we say as molecular mimicry. This is something we say as molecular mimicry. The antibodies which are formed against M protein of streptococcus. Antibodies formed against M protein of streptococcus, they react with the heart. Antibodies formed against M protein of streptococcus react with the heart, causing carditis. So it is a so-called molecular mimicry. The antibodies, they were formed basically against the M protein of streptococcus, but they react with the heart. Now the point important to remember here is universal finding in heart is. And universal finding in heart is endocarditis. Answer is not pancarditis. Pancarditis can be seen, but always endocarditis should be there. If there is no endocarditis, you cannot say this is rheumatic fever. So universal finding in the heart is endocarditis, right? Then there can be pancarditis. There can be pancarditis, but endocarditis should always be there. If there is endocarditis, the heart valves are affected. Heart valves are affected. And the question is, which is the most common heart valve affected? Mitral valve, more than aortic valve, more than tricuspid valve, more than pulmonary valve. The simple one-liner question, least common valve affected is which valve? The answer is the pulmonary valve, right? In acute rheumatic fever, what you get is mitral regurgitation. Mitral regurgitation. In rheumatic heart disease, what you get is mitral stenosis. Because rheumatic heart disease is something which is chronic inflammation. And you can very well understand chronic inflammation always causes fibrosis. So if there will be fibrosis of the mitral valve, it will result in what? Mitral stenosis. This will result in mitral stenosis. So these are the points which you need to remember in the subclinical or clinical carditis. Then the second point here is the arthritis. Arthritis. And this mainly involves large joints. Large joints. And particularly which joints are affected in rheumatic fever? This involves the elbow. This involves the wrist, this involves the knee joint, this involves the ankle joints. So mainly this involves the large joints, hip joint, spine, and small joints of hands and feet. Small joints of hands and feet and spine are usually not involved. The hip joint, small joints of the hands and feet, and the spine, they are usually not involved, right? Then here, there is dramatic response to salicylates. There is dramatic response to the salicylates. If there is arthritis and that does not respond to salicylates, rheumatic fever is unlikely. And they are non-deforming. They particularly are non-deforming, right? So this is the second, what we say is the arthritis. Third criteria you can get here is the erythema marginatum. Erythema marginatum. Now this is important point to be remembered, never present on face. It is present on trunk and proximal part of limbs. Proximal part of limbs it is there, but this is never present on the face. You need to remember here, it is a erythematous, it is serpiginous macular rash with pale center, and it is non-pruritic. So itching is not there. This is erythematous serpiginous macular rash which has got a pale center and it is non-pruritic. Now if you see here, this is something erythema marginatum. You can very well appreciate in this picture. There is erythema present, center is pale which is there, right? And this is usually present on the trunk and this is not present on the face. This is the same erythema marginatum which is there. You can very well appreciate here a margin of erythema, pale center is there, and overall this is non-pruritic. Then fourth important what we remember here is, fourth is subcutaneous nodules. Subcutaneous nodules. And they are never present as sole criteria. You will not find them as the single criteria which is present in rheumatic fever. So it is never present as the sole criteria, right? There is a close correlation. There is a close correlation with carditis. So if subcutaneous nodules are present, that means highly chances of carditis being there. So close correlation with carditis. They are present on extensor surfaces of both large and small joints. Both large and small joints. They can be present near spine and they can also be present in the scalp. They can be present in the scalp. The important point is it is non-tender. There is no tenderness present. It is non-tender. It is freely movable. It is freely movable. Tender nodules you get in infective endocarditis. You don't get here. Here this is non-tender and these are freely movable, which is there is. They are not transient. They are not transient and they can persist up to weeks. They can persist up to weeks. Then important here is subcutaneous nodules. Are they only seen in rheumatic fever in the child? No, they can also be seen in. They can also be seen in particularly rheumatoid arthritis. They can also be seen in the rheumatoid arthritis. So this is the subcutaneous nodules where the arrow is being pointing over the extensor aspect here. This is again present, the subcutaneous nodules with the arrow, and this again is a subcutaneous nodule. The subcutaneous nodules, they can be particularly seen, they like this. Fifth major criteria is the Sydenham's chorea. Sydenham's chorea, right? Although I always discuss this topic in detail along with the nervous system, which we cover in our regular classes, but here this is Sydenham's chorea, and the concept here is antibodies which are formed against acetylglucosamine. Antibodies which are formed against acetylglucosamine, they react with lysoganglioside present in basal ganglia, which particularly causes dopamine release. And due to this dopamine release, there is presence of chorea. Right? So normally in the diagnosis, what we have said already, either there should be two major criteria or one major plus two minor plus evidence of streptococcal infection. But according to the Parkes textbook of pediatric cardiology, there are exceptions to the Jones criteria and they include the following two specific situations. Chorea may occur as the only manifestation of acute rheumatic fever. So in the acute rheumatic fever, you might get the only manifestation, that is the chorea. No other minor features, no other evidence of streptococcal infection, and this is because there is a long latent period between streptococcal pharyngitis and chorea. So in this long latent period, getting those things cannot be there, right? So there can be long latent period. Second thing is indolent carditis may be the only manifestation in patients who come to medical attention months after the onset of rheumatic fever, right? Child had subclinical carditis. No other feature was there, or it was simple fever also, or it was simple so-called ESR increase, CRP increase. Nobody took care at that time. So child is coming months after to us and there can be only carditis which can be the feature present. right? So these are the two exceptions to the Jones criteria according to the Park textbook of pediatric cardiology, right? So we have covered here all the features particularly of the rheumatic fever. Now we particularly go to the treatment part. The treatment part, and in the treatment part what you need to remember is one thing is the bed rest which is there. Second is the anti-inflammatory therapy. Anti-inflammatory therapy which is being given is, and third is what is the role of the antibiotics. What is the role of the antibiotics? Right. So basically if you consider main therapy which is required here is that is anti-inflammatory therapy. Now the treatment I am telling you is from the 7th edition of the Park's Pediatric Cardiology. The treatment is according to this, and this is particularly being written which I have made in a tabulated form so that I can easily explain to you. Three things first important is, one is the bed rest and second is the anti-inflammation. So anti-inflammation is by prednisone and aspirin, and according to the literature, if there is arthritis alone, bed rest is also for 1 to 2 weeks and aspirin is also for 1 to 2 weeks. But if it is mild carditis, it is 3 to 4 weeks bed rest, 3 to 4 weeks aspirin. Moderate carditis is 4 to 6 weeks of the bed rest and 6 to 8 weeks of the aspirin. And in the severe carditis or CHF, then the bed rest is as long as the CHF is present, and you need to give here two drugs. You need to give prednisone plus aspirin, right? And as first prednisone is given, that is given in a dose of, so right here particularly in the severe carditis, along with plus minus congestive heart failure, first you particularly give is prednisone, and the dose you are giving is 2 milligram per kg per day, and this is usually you give for 2 weeks, and then you start the tapering of the dose. And when you taper, at that time you particularly add the aspirin. And the repeated question has been total duration. Total duration is how much of the treatment? The total duration of the treatment is 12 weeks. Total duration of the treatment has been a repeated question, that is the 12 weeks. Then what is the role of antibiotics? Now antibiotics, we talk of the role here. First is the primary prevention. If someone gets streptococcal pharyngitis and antibiotics are started before 9 days. Antibiotics are started before 9 days of streptococcal pharyngitis. This prevents rheumatic fever. Right? So this is the primary prevention. Then is the secondary prevention. Now why this secondary prevention is required? What you need to know is, in rheumatic fever, there is 50% risk of recurrence. Maximum chances of recurrence are in first 5 years. So always in the rheumatic fever, there are chances of recurrence 50%, and maximum chances of recurrence is what? Of within 5 years of the first episode. There is the recurrence. And in the recurrence, if there was initially carditis, now this can be more carditis. And if it was no carditis at all, there can be stepwise involvement of the heart. So therefore, there is always what can happen in the recurrence, there can be increase in severity of carditis. So for this secondary prevention, you require to give particularly is what we require to give is the drugs, right? So for secondary prophylaxis, what drugs we are giving here is, one you can give is benzathine Z, penicillin Z, benzathine, 1.2 million units every 4 weeks in low risk. low risk. But every 3 weeks, in moderate to high risk. So in India, if you see 1.2 mega units of benzathine penicillin G is given every 3 weeks. Second is penicillin V. This can be given 250 milligram twice daily by oral route. Third is sulfadiazine or sulfoxazole 1 gram once a day, and that is by oral route. Right? This is we use particularly for chemoprophylaxis. And if person is allergic to penicillin or sulfonamides, then we can give is macrolide antibiotics. So this is what you need to remember, why this requirement of secondary prevention. Last here is what is the duration of chemoprophylaxis? What is the duration of chemoprophylaxis? Right? If there is particularly arthritis alone, that means there is no carditis. So the duration is 5 years or till 21 years of age, whichever is longer. It is 5 years or till 21 years of age, whichever is longer. Second, there is carditis without residual heart damage. There has been no damage to any heart valve. There is only carditis. So this is 10 years or till 21 years of age, whichever is longer. Third is carditis with residual heart damage. There has been some damage to the heart valve. So this is their carditis with residual heart damage. So what we say here is 10 years or till 40 years of age, whichever is longer, and preferably lifelong. Right? So this was the discussion of an important topic, rheumatic fever. I tried to cover here all the points. For more topics, do subscribe to this channel, continue watching this channel. Your suggestions are always welcome. Right? Thanks.